Children with special health care needs are children who have chronic physical, behavioral, developmental, or emotional challenges, who often require unique health-related services which are not typically needed by the average child. Many of these children are technology dependent. The general principles of PALS apply, but their technology dependence creates a special resuscitation circumstance. This video demonstrates common technology and selected interventions. Appropriate assessment of children with special health care needs must be done within the context of their underlying condition. Baseline vital signs may be out of the range of normal for the child's age. The child may be smaller than peers of the same age. He could have developmental, cognitive, sensory, or motor challenges. Sometimes the ability to speak or communicate is impaired. Because of these factors, it is important to rely upon those that know the child well, such as family and the child's usual caregivers. In this video, we will specifically focus on common interventions and emergencies related to children with tracheostomies, central venous catheters, feeding catheters, and cerebral spinal fluid shunts. A tracheostomy is a surgical opening into the trachea beneath the vocal cords which allows direct access to the lower trachea and lungs. Tracheostomy tubes come in various sizes, materials, diameters, and lengths. They are usually identified by inner diameter. Tube size and type, neonatal, pediatric, or adult, are noted both on the packaging and on the wings of the tracheostomy tube. Some neonatal, pediatric, and adult tubes may have the same diameter. The main difference is tube length. Adult tracheostomy tubes frequently have an inner cannula and fenestrations. Neonatal and pediatric tracheostomy tubes usually do not. Neonatal and pediatric tracheostomy tubes are typically inserted using an obturator or stylet. Tracheostomy tubes can be cuffed or uncuffed and may have a standard or custom design. You should become familiar with the types of tracheostomy tubes that you encounter in your community. This video will demonstrate one basic approach to care of children with tracheostomies. If a child with a tracheostomy shows signs of respiratory distress, the DOPE, or DOPE mnemonic, reminds the provider to check for the common causes of acute deterioration in respiratory status. D is for displacement. Is the tracheostomy tube displaced or disconnected? O is for obstruction. Is airflow through the tracheostomy tube obstructed? P is for pneumothorax. Is the child showing signs of a pneumothorax, such as asymmetric chest rise or unequal breath sounds? And E is for equipment failure. Is the oxygen supply intact, equipment connected, and equipment functioning? To clear a suspected tracheal tube obstruction, first optimize patient position. Often a towel roll under the shoulders improves access to the neck and tracheostomy tube. Assemble and check your supplies. Prepare to suction and replace the tracheostomy tube. Next, provide manual ventilation with a bag valve device via the tracheostomy tube. Select a suction catheter that will fit through the child's tracheostomy tube. Typically, you will use a 6 French to 10 French catheter for this purpose. Disconnect and suction. Do not exceed 100 millimeters mercury vacuum pressure. For routine suctioning, insert the suction catheter no further than the length of the tracheostomy tube. Passing the suction catheter beyond the distal tip of the tracheostomy tube could cause trauma to the wall of the trachea. With the catheter between your fingers, use a twisting motion to suction all sides of the tube while gradually withdrawing it. Suction is applied for no more than 10 seconds. If secretions are thick or obstructive, instilling up to 3 milliliters of sterile normal saline can loosen secretions. If tracheal displacement or complete obstruction is suspected, it may be necessary to change the tracheostomy tube. When choosing a tracheostomy tube, verify the appropriate size by checking the wings of the tube. In this example, we will demonstrate changing an uncuffed tube. On the child, either cloth or Velcro ties commonly hold the tracheostomy tube in place. If time permits, ensure the replacement tube has the ties attached prior to insertion. Remove the ties that hold the current tracheostomy tube in place and then remove the tube. Lubricate and gently insert the replacement tube into the stoma with the curve pointing downward, following the natural curve of the stoma. During proper placement, you should feel little to no resistance. Once in place, manually ventilate and confirm tracheal tube position by chest movement, breath sounds, and, if appropriate, pulse oximetry and exhaled CO2 detection. Then secure the tracheostomy tube in place. When changing a cuffed tracheal tube, deflate the cuff prior to tube removal. Connect a syringe to the valve on the pilot balloon and draw out the air or water until it collapses, reflecting that the cuff has been reliably deflated. Do not cut the balloon, as this does not reliably achieve adequate deflation. Once a replacement tube is in place, make certain to inflate the cuff to prevent air leaks. Do not overinflate the cuff, as this could obstruct the airway. The stoma site may cause a lot of resistance to replacement of the tube. If this occurs, lubricating the tube with a sterile, water-soluble lubricant may be helpful. Consider inserting a smaller tracheostomy tube. Sometimes a suction catheter, with the thumb controller removed, may be placed through the stoma and into the trachea. The tracheostomy tube is then threaded over the suction catheter, which acts as a guide. Standard endotracheal tubes may be substituted for tracheostomy tubes if needed. If a tracheostomy tube cannot be inserted through the stoma, consider oral tracheal intubation. Often, one can provide adequate oxygenation and ventilation using standard bag mask ventilation while occluding the tracheal stoma site to avoid air leak. In children with special healthcare needs, feeding catheters are often used to provide supplemental nutrition. There are many types of feeding catheters and tubes. Many gastrostomy tubes require an adapter to access the port and aspirate air from the stomach. Regardless of the type of feeding catheter a child has, identification of cause for feeding catheter problems can utilize a slightly modified DOPE mnemonic. D is for displacement. Is the feeding tube dislodged? Surgically placed tubes that are dislodged need to be replaced to avoid stoma closure. O is for obstruction. Is the tube obstructed? If the obstruction cannot be cleared by flushing the catheter, tube replacement may be necessary. In this case, P stands for pneumoperitoneum, also for peritonitis or perforation. And E is for equipment failure. Are there any connections leaking? Is the feeding tube hub cracked? Is the feeding pump failing? Central venous catheters are placed in children to provide fluids, parenteral nutrition, medications, and blood products directly into a central vein. Long-term central venous catheters are placed in the chest, neck, arm, or groin and are tunneled under the skin from the entry site to the central vein. Some catheters are accessed at a site outside of the body. Others require a needle to access a port because the catheter is completely subcutaneous. In an emergency, blood samples can often be drawn through central venous catheters. Emergencies that arise from central venous catheters in children can also be evaluated using a modified DOPE mnemonic. D is for displacement. Central venous catheters can be inadvertently dislodged, which can cause a life-threatening emergency. If bleeding is present, apply direct pressure over the site. Subcutaneous air or swelling of soft tissue may also indicate catheter displacement. O is for obstruction. The catheter may be kinked or clotted. P, in this case, stands for pneumothorax or pericardial tamponade. Perforation or erosion of the central vein by the central venous catheter can cause a pneumothorax, hemothorax, or hydrothorax. Erosion of the catheter through the atrium can result in acute pericardial tamponade. And E represents equipment failure. Connection leaks or damage to the catheter or pump system can cause problems. Disconnect and examine equipment and pumps. Manually flushing the catheter often helps to define the problem. Cerebral spinal fluid, or CSF shunts, drain excess fluid from around the brain. The excess fluid flows into a subcutaneous reservoir under the scalp through a subcutaneous tunneled catheter. This usually drains to the peritoneal space. Alternate drainage sites include the pleural space, right atrium, and gallbladder. A child whose CSF shunt is not functional can develop increased intracranial pressure, necessitating emergency action. Additionally, fever, abdominal pain, nausea and vomiting, or tenderness at the shunt site could reflect a shunt-related infection. Once again, a modified dope mnemonic may help localize the problem. D is for displacement. Is the CSF shunt displaced? O is for obstruction. Obstruction is the most common cause of CSF shunt failure and emergencies. Is the shunt obstructed? Blood clots or protein precipitates may block the catheter. P is for peritonitis or perforation. CSF shunt catheter infection may lead to peritonitis without disturbance of bowel integrity. Alternatively, the shunt may erode or perforate the bowel. Are there signs of peritoneal irritation or free air? And finally, E is for equipment failure. Are there any leaks, cracks, or fractures in the shunt or its connections? Children with special healthcare needs often have chronic illnesses that make them susceptible to acute medical problems. When medical emergencies arise, it is important to use caregivers and family members to supply information concerning the child's medical history, baseline vital signs, and activity. A standard emergency information form is a good tool for communication. Practice rapid initial assessment and use the DOPE mnemonic to quickly identify and correct problems with artificial airways or equipment. A slight modification of the DOPE mnemonic is useful to identify common causes of problems that require acute intervention in children with special healthcare needs. Be familiar with various technologies that help support children with special healthcare needs in your scope of care and community.